Everybody, welcome to another Expert Talk series. Thank you so much for being here with us. Shows us that we're doing the right thing for each of you. I just want to mention that you folks at home who aren't with us today, and you're going to be watching this on YouTube, it would be really nice, as you've heard many times before, if you could press that subscribe button, because we want to spread this message as far as we can. And other than that, also, I would like to say, you might have a minister or you might have your doctor who's not aware of what we're offering. And information is power. So when you can, share that this is happening, and people that you don't even know could be benefited. So thank you very much. With that, I'll turn it over to you, Christian.
Thank you so much, McFinn. And I'm happy to be part of the team here welcoming Dr. Eduardo Locatelli to join us this evening to talk about how to slow ALS progression. So we'd like to welcome Dr. Locatelli, who's the Nova Southeastern University Health Neuroscience Institute, medical director, and he has previously served at Holy Cross Hospital in Fort Lauderdale. At Holy Cross Hospital, Dr. Locatelli led the creation and development of the Phil Smith Neuroscience Institute. His deep involvement in ALS research includes clinical trials sponsored by the Sean M. Healy Center for ALS at Massachusetts General Hospital, ALS genetic studies, and expanded access programs. He's responsible for the first ALS Center of Excellence in Broward County in Florida, and Dr. Locatelli also pioneered programs for patients affected by epilepsy, Parkinson's disease, movement disorders, migraines, and stroke. We're delighted to have you join us today for what promises to be a really enlightening and engaging discussion. And just as McFinn mentioned in the beginning, we do have a Q&A segment of the program. But of course, throughout the program, feel free to use the chat to ask your questions, to raise your hand if you have a comment that we'll make a note to call on you at the end of the presentation. And of course, feel free to connect with your fellow attendees in the chat as well. So with that, Dr. Locatelli, we hand it over to you. Welcome.
Well, thank you very much for the introduction. I would like to add that since I moved to Nova, my practice is now continue to focus on ALS, and actually most of what I do today is in ALS, despite done other programs like you mentioned before. Putting teams together, I have committed now my practice and probably for the remainder of my neurological career to commit to look for the cure of ALS. Lately, we had a patient and her husband that give a donation. So now the institute is called the Kathy and David Hassman ALS Center. And that is because we need the indication is to find the cure. So we are going to focus on providing care and really aiming to help the community to find better treatments and do better every day, and trying to do it as fast as we can, which is what we all want to see. So I want to add that to what I'm doing now. Should I go ahead and start with the presentation, I guess?
Yes, please.
I'm going to go ahead and share the screen. And put the presentation here.
Yes.
And so here are my disclosures. There's nothing but the supporting of the research. We have grants from the Department of Defense and the ALS Association, and we're doing a lot of clinical research. Some of the ones we initiated, but then in terms of financials, the Healy platform trial and expanded access programs, particularly the Amylyx and Clean Nanomedicine companies. I would like to outline the presentation. I want to give you some of the baseline care that I think is very important when you're trying to slow down ALS progression. You have to know that it's almost as important as the medications or the combinations of the medications. The baseline care is something that have to be provided. I'll spend some time particularly giving my philosophy about how that baseline care should be. I would not be able to leave the room without giving you some of the updates that we learned in MND-ALS in Basel this year in December, all the updates. and give you some of my ideas of what I call the current future, which I think is now changing very quickly. So what is that I think about the baseline care? I truly believe that centers of excellence, whatever it is that is nominating you, but particularly those that have multidisciplinary clinics, are the places that the ALS care should be done at. Particularly, there will be aspects of how you access that clinic, but also the support that you have in your home and around you, because that is extremely important for slowing down the progression. And something that I might touch a little bit is, what is our personal view on life and end of life and death? Some patients focus on the quality, and some other patients want to be just time. And this is important in trying to decide how long you stay around. And sometimes that really depends on what the personal desire is about to stay alive, or to say, okay, I've done it and this is good enough for me. So this is important in the ALS progression, is the decision how you're going to fight it, or how you're going to just try to end it when it's time. So the center of excellence is key. The diagnosis of ALS today still doesn't have the ultimate test. EMG is the test that we all look forward to see some abnormalities, but we still don't have the magic test that says, you have it because of this test is positive. Also, the center of excellence will help to, come up with an earlier diagnosis. If there's confusion, the center of excellence usually will expedite the diagnosis. But not only to make the diagnosis, is to look into what is the individual features, what is your individual progression rate, and how you come up with an individualized plan. The center of excellence are good about doing this part. Usual general neurologists don't have the bandwidth to actually do a full assessment from head to toe and trying to anticipate how your progression rate will be. And then these centers usually have quick ideas to come out what are the interventions, so you can have them earlier, and also give you information, update information. What are the new FDA-approved treatments? What are clinical trials that you might participate in? If you don't qualify for the trials, do you have an expanded access program that you can receive a medication? What is the opinions of off-label treatments? And everything else. The internet today is loaded with information, sometimes misinformation, just being old, in which patients want to try these things. And sometimes the centers of excellence can advise that something might not be valuable, or maybe too expensive, or maybe not worth it, or some other information that say, well, there's not a lot here, but it might be beneficial to you, even though it's not an approved treatment, or it's something off-label, like supplements and things of that nature. The multidisciplinary clinic is key because not only we have a broad knowledge about an ALS, but the knowledge is very deep. So the information that a physical therapy or the speech therapist or the different members of the team will be able to provide a knowledge that is much more deeper that the neurologist can have. And I rely on their opinion all the time. And actually, the recommendations are almost never just my own recommendations, are the team recommendations. And for that, you need to have a very good coordination of care. So it has to be integrated. The team needs to usually meet before we see everybody. Then we see everybody and discuss the case and everybody. And then after that, we discuss it again and to make sure that we don't miss any other recommendations. Also, it's very important because it's one visit for the patient, but be able to see many providers. That avoids the having to go to the different providers that takes so much time. Nowadays, the multidisciplinary clinics, particularly after COVID, now we have not only the face-to-face visit, but also virtual encounters. And I think at least our clinic is also providing virtual multidisciplinary clinics. So in a video conference, we can have several members of the team and be able to address the issues in virtual visits. And also, the multidisciplinary clinics, particularly with psychologists or social workers or information from some of the respiratory therapists and the physical therapists, we can learn a little bit more about how is the home environment and be able to make recommendations that are actually more practical. Sometimes we make recommendations that are very difficult to implement. The other point about the progression and ALS has to do with medical access. And here is when the clinic is very valuable, because you do one visit and you see many providers. And also these clinics can have different formats. It's not only the visits face-to-face or virtual, but a lot of times just the phone calls or sending texts with quick questions or emails with more information, or trying to do an impromptu video encounter to actually do an assessment of something that has come out in between the clinics. So access is key, because if you can prevent a pneumonia or can help with an infection in time, it will save you an admission. It will save you going to an emergency room. So having access to the clinic, not only on the scheduled visits, but also in between them, it can be extremely important for the to slow down the progression. And the home support in terms of progression is very important as well, because people will need a lot of tools at home to maintain independence. And also the home support is important because many of these therapies depend that others will help you to actually implement them. Needless to say, if you don't have insurance, everything is very expensive. It's very challenging. So insurance, home support, access to this is key in the progression. Sometimes we don't pay enough attention to these details to use them and trying to prevent the progression to go fast. And then history sometimes is quite important. Some patients really don't trust the medical system. And I hope that the Center of Excellence will sort of rebuild trust in the medical system, that you don't have to wait long for an answer, that you don't have to wait long to actually get the medication approved. If the medication is not taken, it takes several months before it gets approved, so you miss opportunity to slow down the progression. Now, social support, I think sometimes some of these issues are even more important than any of the medications I'm going to talk about later. Because if there's no financial resources and there's no savings on financial reserve, or there's no insurance, or somebody only speaks a language that the Center of Excellence doesn't speak, these barriers are really key in understanding recommendations and implement the recommendations. Understanding the home environment is key. There are people that have homes that are really a challenge. It's narrow doors, several steps, difficult to enter, etc., etc. This is very important to make sure that you prevent falls, or you can have access to some of the things you need to stay independent. Ways of transportation at the beginning is like anybody else, but later the transportation becomes a big challenge. And also the distance to the clinic, particularly if it's long, there will be fatigue in these transportations, so on and so forth. And also technology. Some patients are computer savvy, but sometimes there's the phones are not powerful enough. The Wi-Fi is weak. So if you're going to do virtual visits and things like this, sometimes this become a problem as well. And this is, I think, for what I gathered in this group, people have been thinking about this probably more than I have. But religion and faith is very important. Some people, don't believe on this, and there's some power that comes out of this. Issues like what is the role that you had within your family? Were you the provider, and then you had trouble accepting help? Recently, I had a patient that she was really distressed because she always was the provider, and now she really disliked the role. And not receiving the help actually was stopping her from receiving something that was going to be very beneficial to her. And then the support that you may have with partners or your children or grandchildren is quite important. And your personal view on death. Some people are really afraid, and some people are really not. And this is key in how you view your progression and how we all at the end going to die. So this, what I just mentioned, is all these other issues that I think are very important for not only the patients to have a view on them, but also the clinics to have a view on them, that these are key determinants of the progression rate on ALS. But let's move on into something that maybe you guys want to hear more than the things that I just mentioned before. And then what are the current therapies? And these, for what I gathered, the group knows, and I don't know if everybody's in the same stage, but just putting some of the baseline here is, these are the the most common medications: Riluzole, edaravone, PV-Turso combination, and tofersen. These are the FDA-approved medications. Also, we should not forget the two studies actually, and the ultra high dose of methylcobalamin or vitamin B12 injections, which has had significant decrease in the progression of ALS. And we'll show some graphs about that later. In our clinic, we have a tool called the CareSense tool, in which we keep track of all the functional scale, the so-called ALS FRS revised of ALS functional rating scale. And here you see over time how the scale is changing. And this is important to know because if we are achieving a slow down the progression, we should be able to see it in this graph. And on the right, we have the vital capacity, which is the measurement of, respiratory muscles. In the same way, we follow the progression. At the bottom of the graph, I put the average progression rate for the ELS-FRS is 1 point per month, and for the vital capacity is 2 points per month. I have rounded those numbers. Keep those in mind because I'll show some things that I hope I can explain simply, even though the concept might be a little bit difficult. In this busy graph, I put those medications and trying to see what are the benefit of them individually. The first bar, called the PROACT, is the one that shows the ELS-FRS changes at about 1 point per month. And it comes down because it's a progression. It's a minus 102. Next to it, you will see edaravone. And in red is the placebo arm. So these patients were progressing at 1.2 points per month. Next in red is PV-Turso, with these patients, they were progressing even faster. It's a different population. They were progressing at 1.6 points per month. And third is the methylcobalamin, and these patients were progressing at 1.1. Now, in blue, you can see that all of these medications have diminished the progression rate from 1 to 0.8, from 1.6 to 1.2, and from 1 to 0.6. So all of these studies show benefit in decreasing the progression rate. They were significant, and they were the studies that guided the FDA to approve them, except the methylcobalamin, as it's a supplement, it was not approved. It didn't require approval. Here's the same kind of graph showing the difference in vital capacity. And again, PROACT is about 2 points per month, and all the other medications have shown that there's also a benefit in vital capacity, even though in none of these individual studies was significant. It was a trend, but it was not significant. So in our clinic, we thought, well, now, should we give one of them, two of them, all of them? Is this something that we should combine? Do we have an idea whether it can be tolerated? Do we think they have additive potentials if we give them all together? So we have this hypothesis and said, well, if they're good individually and they work in a different mechanism of action, if we give them together, they should do better than if we give them individually. We review 110 records, and we find about 31 patients that were taking all 4 medications. I'm sorry, that I had data that it was more than 3 months. They were in stable treatments. And then we divided between the ones that were taking it versus the one that were having partial treatment. So for some reason, they were taking maybe one, they were taking it for some time, they were not compliant, or they could not afford it. For some reason, some patients were not taking all of these medications in a consistent way. Here are the features. They're similar. There was 16 in one group, and the one that had some treatment, and there were 15 in the ones that had complete treatments. And the clinical characteristics were very similar. If anything, the full treatment were a little bit more of the male predominance, and maybe they were a little more longer disease and a little bit older. Now, here are the results. The patients that took partial treatment or no, they were progressing at that rate of 1.2 points per month. But the ones that were taking all the treatments were really much better. They were only progressing even less than half. So there was a significant benefit on using the combination treatment. And the p-value, which is the significant, this was a true finding. They were better if they take the combination as compared to partial treatment. The same graph looking at the vital capacity. Again, the partial treatment will progress about 2 points or 2.9 per month. The ones on medication, the full combination, much better. And here it was significant as compared to the individual studies. So in this graph, I was trying to compare what is the clinical impact. So if you look on here, the difference between 2.9 and 0.86 is the benefit. If you see what is the percentage of one compared to the other. And the functional scale, the combination was remarkable, a 63% benefit. Individually, we're about 34 to 25% or 43%. And again, I want to mention that it's not here to compare the different drugs, but this is because they were different populations. But we can clearly see that the combination did better than the ones published for individual treatments. And when you look at the vital capacity of respiratory muscles, even better, 70%, as compared to about 20% if you give them individually. Let me spend a minute here because I also want to point out one thing, and this is the benefit that you may get on Riluzole. Riluzole was published in 94 and approved in 95, so many years ago. And about 2 years ago, in Muscle and Nerve, they published important information about this large data set. And what this shows is that if you take Riluzole earlier, the benefit is significantly better. So if you start within the first 6 months since your onset, you get a benefit of 6 months. If you start within the year, it's 5.3 months. If you start within 18 months, it's 4.2. If it's 24 months, it's 3.1. If you start after 30 months, you only get 1 month of benefit. So if you go to your neurologist, they will say, well, the benefit of Riluzole is about 3 to 6 months. Well, 3 months is if you started within 2 years, and 6 months if you start right away. So the point here is the earlier you start Riluzole, the more benefit you're going to get. But this is only Riluzole. We don't know if you combine Riluzole with everything else, is it going to be better than by itself? And the data that I present to you, most of the patients were taking Riluzole. So out of the published studies, individuals gains for Riluzole, as I mentioned, the study I quote is 5 months if you start within the first year, which is what most patients would do. Usually there's a delay in the diagnosis for about a year. So rarely people will start Riluzole even before that. But if you start Riluzole right away, you'll gain about 5 months. Edaravone that didn't have very good data on that, but recently they published something called the claims data out of the insurance, and they think that the benefit with the Edaravone is about 6 months. And here with the Relivrio, it says if you take it for 14 months, the benefit might be 16 months of survival. And if you use B12 injections, 50 milligrams twice a week, and you take those within the first 12 months, then you might get about 20 months of benefit, which is probably the one that has the better benefit. Again, this information is indirect somehow, is difficult to follow, but clearly shows that these medications individually give you a survival benefit. And based on what I look in my practice, if you take them together, probably you're going to do even better. So in summary is that it seems that the combination is beneficial beyond the individual treatments for both functional progression and respiratory function. The life expectancy, it has likely significantly improved with the combination therapy, and also suggests that if you give it earlier, all of these treatments have suggested if you give it earlier is the better. So if you start after 3 or 4 years, you're not going to get the same gain, and if you start within the first year. And the 30 patients or 31 patients that I review really are not going to validate and show this is 100% the truth. It's at least one finding, but larger study needs to be done to actually validate what I just reported to you. It has a lot of limitations. It was a retrospective study. There was many things that we did not control, like the access of healthcare, whether they have insurance and other things. We didn't exclude for whether you are in the trial or had a PEG or non-invasive ventilation. And there were a little bit difference at the baseline. So it's a small group. So the study has a lot of limitations, but at least it's pointing out that if you can afford and take these medications on a regular basis, it's likely to be better if you take just one or two of them. Let me move into some of the things that I learned in the International ALS meeting in Basel in December. And I added a few things that came just in January of this year. The first point is something that opened my hope tremendously. And it's the report that the patients that were taken tofersen or Qalsody, now commercially available, for those patients that have SOD1 ALS-related condition, only for those patients, which is about 2% of everybody. So it's a very small amount. And those that took the tofersen also within the first year, they reported that the symptoms of weakness reverse. And so this is the first time that science has provided treatment. And when given very early, there's some, scientific approach to reverse weakness. We never seen this before. I know we have a number of patients with reversals, and we're learning about them, but we don't know exactly why they did it. These particular patients are reversals because a medication is specifically targeted to the genetic issue is being treated, and now we see reversal of weakness. After the first year, and particularly after the 3 years, the condition sort of gets stable or the progression is slower. But within the first year, there's reversal. And that is something that remarkable, because that's what we would like to see, is that we have something to reverse that weakness. The second point is there's a report in a phase 2b study. It's a twice-a-day medication. That's the B4. And a medication called Prime-C, which is a combination of an antibiotic and anti-inflammatory. And this is a very small study, but it did show significant in the reduction of ALSFRS. Everybody's excited about this because this antibiotic and this anti-inflammatory are on the market, and people like to think about whether to use it earlier. But at least the company is now thinking of going for a phase 3, a larger study. The combination has specific dosing, a specific formulation, is pharmaceutically grade, and they're looking forward to see if they can run a phase 3 study on this finding. In the negative side, we have the report of another study, ADORE, which is the oral, a complete different oral formulation as it is Radicava. It's not the same formulation, it's a different one. But this was done in Europe and other countries, but also using edaravone every day. But they terminated the study. They didn't find significance. So everybody's thinking about this and trying to transpolate information from one to the other. In my opinion, the data that we have and the IV edaravone is not the same as this compound. So there's some differences. So this is not to say stop Radicava, but this is a report of a very important study that we were hoping to be given oral Radicava instead of just 10 days a month. The other two studies that have shown nice trends were studies that came out of arms that came out of Healy from a company called Clean Nanomedicine. This is a compound with gold. And now they showed an increased survival in a couple of studies. And now they have an expanded access program. They actually had expanded access program. They're just increasing the number of opportunities now for enroll in the next, potentially started in March, to be able to expand and have other patients taking this. It's essentially a bottle of water with crystals of gold, very minimal or no side effects. But also the company is looking into doing a phase 3 study to be able to have it approved, and everybody will be able to get it. The other one is predopidine, which is also another arm of Healy, and it showed the benefit in voice and swallowing. And now, in about 2 or 3 weeks, we're going to have the expanded access program available, and they're thinking about doing a phase 3 as well. So these are two compounds that have shown benefit. They're expanded access programs, and the companies are likely to be moving on phase 3 studies. So this is remarkable and adds to something that was also presented in Basel, which since the approval of Riluzole in 95, there were many studies and a lot of money invested in the studies, and they all did not show benefit. But in the last 3 or 4 years, we probably counting about 6 or 7 medications that have benefit. So this is to show that, okay, we have treatment opportunities, but also it's showing that the scientific community is now understanding the pathology better. The science is close to really understand much more ALS pathology, and the medications that we're trying are really much likely to work than the ones we tried before. And this brings a lot of hope. And I want to point a couple other things. One is that there's reports now a high caloric index nutrition can also be a disease modifying treatment, can slow down progression. So things like macaroni and cheese or French fries or things of that nature that will raise the sugar very quickly, kind of nutrition that can slow down the progression. This will require assessment with nutritionists to try to make sure that we understand your weight and your height and trying to address this particular nutrition a little more specific. But there's something about good nutrition, particularly with high calorie, that it will slow down the progression. And also that the non-invasive ventilator, so these ventilators that we use with masks or different appliances to the face, when put in the right settings and the patient tolerates them well, can slow down progression. So it seems to me that it's very important to eat well and breathe well. And the information now is if we have the right nutrition and the right support and ventilation, we will slow down the disease progression. So these are two things that really, in multidisciplinary clinics, when assessed properly with the right recommendations and follow up through, it can be very, very helpful in keeping the condition at base and without progressing. There's a lot of also research going into these so-called frontotemporal dementias. ALS in general terms, people they're very bright, they participate in their treatments, but there's a portion of patients that do have problems with cognition. And there's a whole lot of research, particularly in a genetic condition with something called C9orf. There's a lot of research and new genetic approaches are aiming to this particular kind of ALS. So a lot of heavy research is in there, and we expect that there will be treatments probably within the next 24 months. The other is, and genetics is exploding the amount of data, and it's beginning to teach us what the problems are, and it's helping us to understand better to pick the better medications. And also, I think we are closer and closer to have biomarkers to see the ALS functional scale is not the best way of measuring progression. It is the best we have today. We are looking for biomarkers, particularly something called the neurofilaments. They are becoming to be more and more reliable. There's many others, and maybe combination of them, that will help us to trying to screen medications easier and quicker. So we put a lot of emphasis on those that have more chances of work, rather than doing very long trials that have low chance of succeeding. And the last point here is probably one of the largest issues that we're going to be facing, because genetic forms of ALS are becoming more and more prevalent. We have reports that maybe 10% of people with ALS have a genetic problem. The number is going up, maybe 15%. Today, I look at our practice. We have about over 100 patients that we have genetic testing. We have 26% of them have some related to genes. So I think the genetic causes of ALS were going to be a little bit higher than we thought before as we discover other genes and we test more people. But also the issue, once the patient is now diagnosed with a genetic form of ALS, now there's an explosion of cases because now can be several family members that become positive. And these are now carriers of the gene, and they have a question. So what do? We just sit and wait? Can we do something to delay the onset? And if we start having fasciculation and weakness, can we treat it day one? How can we stop it? Can we get arrested day one? Can we prevent it from starting to begin with? or what do we do if we start having some symptoms? And the number of people with ALS, depends how we read, is 30 to 40,000 here in the United States. And the calculation is probably about 200,000 of gene carriers. So it's the order of magnitude of the issue is maybe 4 times greater than ALS itself in terms of number of patients. And this is what I call current future. I've been looking into these 2 issues lately because artificial intelligence is, and all these new bots that we have are beginning to give support to research in a significant way. Research is going to go a lot faster now. It is going faster since people are using these things. And also, there's a lot of research in what is called synthetic biology, which is gene editing and gene research, and beginning to do this. When these 2 sciences are getting together now, the time to discover something useful is getting faster and faster. I quoted here somebody that I've been reading from, is a historian, a philosopher from the Hebrew University in Jerusalem, that the study of the past history is not the study of the past, but it's a study of change. And now it's important because these 2 technologies are changing the speed of change. So the time to finding the useful treatments or the cure of ALS is much closer now because science is going much faster than it was before. And I'm very hopeful that that's going to be the case. I'm looking forward to seeing myself and the next few years we have this in our hands. One issue about decision making, and this hopefully might give me some questioning in the question and answer portion of this. In the past, the way to make decisions, we based a lot what religion or the priest or somebody told us, or what the father or a grandmother figure will tell us what to do. Or sometimes we went to the doctors and think, okay, the chairman of the department is the one that knows the most. And that's where the information came, and how we make decisions were based on those directions. But nowadays, in the present, the decision usually is made based on what we read in the internet, what everybody's thinking about it. In the multidisciplinary clinic, is not what one person said, but what everybody says. And we study, quote studies, and we quote references to actually support the decision we make. But more and more now, almost in the current future, these AI and algorithms are beginning to give us a lot more power to personalize medicine. So we have tools now that the way to make assessments about individual patient is a lot more accurate. The way somebody's going to progress is going to be a lot more accurate. It's not the same somebody that is progressing very fast and somebody is progressing very slow. And these algorithms will tell us that at the beginning. So in some patients, we have little time to action. Other patients, we might have more time to action. So in the near future, the decision making is going to be changing a little bit more about this. And it's controversial about AI in so many aspects, but I think if you look at the positive things that AI and these algorithms can bring, it's certainly one that is going to be positive for the treatment of ALS. At least that's my opinion. So a few recommendations before we open it up. I strongly recommend that the care for anybody with ALS and their families, they have to contact a center of excellence that has a multidisciplinary clinic. There's so many pluses about doing that. Based on some of the things that I show you today, it's extremely important that we accelerate the time in which somebody gets diagnosis. And this, for this crowd, is essential. This is everything ALS, and Indu Navar has done so much about this. We know that it's over a year it takes to make the right diagnosis. We need to know much quicker because, as I said before, these therapies work when we started the treatments earlier. So we have to do this. We have to accelerate the time to diagnosis. Second, once we made the diagnosis, there's no time to lose to actually start treatment, and particularly if we can start combination treatment. So we need to decrease the time from the diagnosis to the treatment. I've been working a lot with the companies trying to expedite the approval of these medications. I've been working how to actually implement them quickly so everybody will get on board all these treatment as soon as possible as they tolerate it. So these are 2 points that are really important. And third, at least in my practice, it seems that the combination is a little bit better than if you do it individually. But not even the combination therapy is stopped the disease yet. Maybe tofersen, maybe at within the first year, but the other therapies do not stop the disease. So research must continue, has to increase in speed. We have to put a lot more energy, more investment to actually find these treatments. So the current treatments are very hopeful, but we're not there yet. And we have to continue to make everything we can and to have them here. And with that, I will stop and be happy to answer any questions.
Thank you so much for that, Dr. Locatelli. You got some compliments in the chat. We're going to start from the top and work our way through the chats. One of the questions is, you mentioned early on an ultra high dose of methylcobalamin. What is an ultra high dose?
I'm going to stop the sharing so I can see everybody.
Okay, great. Yep.
Okay. Thank you. So if you go to a pharmacy today and trying to buy vitamin B12 supplements, usually it's 1,000 micrograms that is equal to 1 milligram. It may come in 2 or 3 or 4 milligrams, 5 milligrams as a high dose. This is 50. It's 5 times more. So you cannot take enough pills. So it has to be given intramuscular. So it's a needle injected in the muscle, and it's given twice a week. So it's an ultra high dose. It's 50 times what you usually buy in a regular pharmacy, CVS, Walgreens, Publix, any pharmacy you may go. Usually we order through a compound pharmacy, so they can do a liquid form, so it can be in a pre-filled syringe, and patients can inject that twice a week. Sometimes the dose is divided in 2 small syringes of 25 milligrams each, so it can be given in 2 different muscles, and usually they do it, let's say, on a Monday, and then they will do it on a Thursday and repeat that on a regular basis. There's almost no side effects. There's one patient that reported that he had a little bit of pains, but most people sometimes even report some gain of energy. And the other thing is the urine is going to come very pink and almost red sometimes because there's an abundance of that vitamin B12. And we only grab what we need and the rest we pee, so that nobody gets toxic on it. But that's the protocol for injections of vitamin B12.
Thank you so much. What about the effects of Riluzole to the liver?
The Riluzole can irritate the liver. I don't know. I have already several, maybe 500 patients by now in the last 7-8 years. I think I have 2 or 3, so that the liver enzymes will go up. Usually there's a tendency for irritation of the liver. So usually there is a baseline liver enzymes. So we check the enzymes before we start the medication. Then we check it, a couple of weeks, then a month, then a couple of months, and we follow every so often. But it's very unlikely the effect on the liver, even though it's well described, it's in the warning of the medications, or something we have to pay attention to.
And Stacy Lewin asked, what is your opinion of taking methylcobalamin starting after the first year of diagnosis? And this is a bit of a recurring theme of time to diagnosis, but we can start there.
Right. So this is really a very good Japanese study, and the first study came all comers, and they followed them over 4 years. And when they put all that together over 4 years, there was no clear benefit at that point. There was too many patients and only the LFIS. But when they studied a subset, when they studied at the beginning, they saw the benefits. So they went back and did the second study on patients starting the medication within the first year. What they saw is that really right from the first month to the second to the 4th month, there was benefit. Now, it seems like everything else, if you have taken trying to try B12 many years in the future, it's likely the benefit is going to be less and it's going to be more difficult to measure. But like everything else, all the other medications are almost telling us that the most benefit is within the first year. But yet, it's impossible to think that the benefit will not be beyond after the first year. But, if we have somebody that is really super weak after, many, many years, to trying to give injections and muscles that are so tiny, it makes no sense. Now, to tell you what is exactly the date I would not recommend it is individualized, because for those that go very fast, maybe sooner. For those that go slow, I will keep it long term. So I don't stop from giving in the medication if you have 2 or 3 years of the condition. I still do recommend it.
Thank you so much. Mike had a question about the diet, and specifically, does keto diet slow progression, or how might it impact progression?
I don't think we have good data on keto diet, but I think it's not a good diet. A ketogenic diet is something that I have done and prescribed myself because I did a lot of epilepsy on children with epilepsy. A ketogenic diet is a lot of fat, no sugar, 0 sugar. That diet is almost exactly the opposite of what now was reported recently. A diet heavy in sugar, a diet that is heavy in sugar is going to increase the sugar very quickly. Ice creams and bread and pasta and mac and cheese and these kinds of things seems to be extremely important. That's not going to be a good diet for somebody with cardiac conditions and coronaries. They are tight, because that is kind of the opposite diet. But if you do lose weight in a ketogenic diet, I've seen it so many times. Ketogenic diets, particularly if you lose weight, is not a good thing.
Thank you so much. That was certainly an important presentation made in Basel as well, and drew a lot of attention. So thank you for clarifying that. Yeah. What about lithium in UNC13A variants in ALS?
I haven't used it myself. I'm not convinced that that's something that I would do. And then you have to see the variant. I don't have a lot of experience to really be an authority to answer that question, really, but not a big portion of what I do. And I'd be cautious about using lithium. Lithium depends on the dose you take, can cause diabetes, can make you pee all the time. And I would say that will have some income cramps, but I don't have, a lot of experience to actually, give you a very strong response to it.
Thank you. Going back to we've got quite a few more questions that came back to the B12. So can you take sublingual B12, and can you suggest a recommended dose? Thank you, Deborah, for that.
So I think so. I think B12 from methylcobalamin in any large amount has to be useful. The study actually was interesting because they did a high and a low dose. So they did a 50 milligram that I mentioned, but they also did a 25 milligram, half of the dose. The 25 was also beneficial, but the 50 was better than the 25. So, and does it have to be intramuscular? I don't think so. Methylcobalamin will get there, and particularly if it's sublingual. So, but the dose has to be high. So if you're going to take, let's say, 5 milligrams, take it every day. And you probably will get to a high dose around 25 milligrams. So if you want to take something orally in a high dose, 5 or 10 milligrams or 5 milligrams every day, I think probably will be beneficial. Do I have a study to quote you on that? No, I have to transfer information from the one that I quote you in terms of intramuscular injection. There are others researchers coming because there are different forms of vitamin B12. They think they may have more power. So I will not be totally surprised that in the near future, there are some studies on different kinds of methylcobalamin and different ways to give it. But if somebody wants to take sublingual, take a really high dose daily, and that would be beneficial.
Thank you so much for that, for the clarification. For our friend Doug, who's newly diagnosed, is methylcobalamin at B12 a can't miss opportunity, being so newly diagnosed?
If you're newly diagnosed, it's the perfect timing. I don't know if I understood the question. So if you're newly diagnosed, it is the best opportunity to use it. The study is very powerful for the newly diagnosed.
Thank you. Switching gears a little bit, Carl asked, what is AI medicine? So maybe if we can delve a little bit deeper into what do you think the impact of AI can have or is having both in treatment as well as in the research you're seeing?
So AI is a broad term, artificial intelligence. So now there are machines and programs, when large data sets are passed through, they can make the analysis better than we can individually. It doesn't mean they're more intelligent than we are globally, but in specific tasks, they can do better than we do. There are computers that can read data in very large numbers, and they can give us very good information. One example, there's a technology called CRISP, in which bacteria can clip certain genetic code that doesn't belong to the bacteria, so they protect, a virus infected the bacteria doesn't want that, and you can cut it. Well, we're using that technology to remove genes in the research aspect. Using AI now, they find 188 new tools. We used to have the hammer, it was CRISP, and now we have the entire tool set to actually cut DNA, change DNA, doing things like that. In addition, if you study everybody else's genetic code, and we're trying to see what common factors are in there, we can find there genes that can protect against ALS or genes that might prone you to have ALS. So these tools can tell us that answer. Our brains are not powerful enough to look, millions of data points. AI can do that. If we put all the data about progression, then we can predict who's going to go fast, who's going to go slow. So these data sets are helping us to be able to handle large data sets and have answers. They're more accurate than the ones we can do individually with our brains.
I will add a plug, as you mentioned, that we're doing work here specifically on helping stratify the patient population through digital biomarkers and with digital health technologies that can help generate that kind of very nuanced data and give us tools, give our clinicians and researchers like you tools that are far more advanced than what you have today. So I will, for everybody in the audience, both directly, if you'd like to sign up for one of our studies in which we can either study speech or different modalities, different methods of tracking your movements. We are doing observational studies to help that research along and accelerate the incorporation of AI in these diagnostic tools. So we've got the link there for you, and certainly you can speak to the value of improving the tools that we have today.
In your case, the tool has been taught about what normal speech is, and then a number of patients help to feed the database and say, okay, this is abnormal speech. So somebody now can record themselves based on this tool has been trained with large data sets, and the tool can tell you, no, your speech is not normal, and it could be ALS. Go and see an ALS doctor. So that's where AI is helping to make the diagnosis earlier. It might not be 100% accurate. I think over time might be even better than the doctors, but it can help to make the diagnosis earlier. And all the sensors you put on the shoes, on movement, and so on and so forth, that is what I'm saying, which AI can help us tremendously. If AI can help us to make the diagnosis there 12 months to 3 months, what again? We can implement these treatments and we can change the course of the ALS. So this is what we say about AI. And I think, everything in ALS is at the forefront of the diagnosis, even before you get to the doctor. It's a tool that it can be even before medicine is in the front.
Thank you so much. We completely agree that that's the mission. One question as we go along, staying with diagnosis and progression tracking and different types of tests. What's your opinion on using neurofilament light chain blood test as a marker of progression, as opposed to, right now it's being used heavily as a trailing indicator in trials?
So I think there's still a little more to learn about it to be 100% comfortable with the neurofilament. So neurofilament is a product of dying neurons and axons. So when a neuron axon die, the neurofilament goes up. Now, if we give a treatment that is effective, preventing neurons from dying, the neurofilament should come down. And so it's a nice biomarker. Example, if the cholesterol is high, you're at a high risk of coronary disease. So we bring the cholesterol down, at least we think you're going to have less likely a chance to have a heart attack. Now, tofersen, this very specific treatment, showed that it did decrease the neurofilament, and that was very important for the FDA to approve it. The other medication with clean nanomedicine also showed that it looks that the neurofilament seems to go down, and that was reassuring that they were, hitting target, and the expected effect was coming down. So right now, I think it's extremely useful when you look at the entire cohort. The problem comes, okay, what about if I check it on only one person? If it's high and I can do a treatment, I bring it low, is that something that I can trust? It is individualized. And that is a question about that, because I think we need to look into the change from one to another rather than the single number, because many things can increase the neurofilament. And ALS usually is very high. So I think the information about individually testing neurofilament and how we're going to use it clinically is not so clear yet. We're beginning to use it particularly in defined cases, so people have genetic ALS. And if we have a baseline that is at this rate, and then somebody starts having fasciculations or start developing weakness, and we see that it went up, okay, something is happening. And if we implement the tofersen treatment, for example, and it comes down, then we're on the right direction. So we're beginning to use it, and I think it's the beginning of that information. It's not so clear to trying to use it with the rule for everybody that we know exactly what's going to happen. But it's a very good marker right now. It has a lot of science. Scientists very excited about using it, and it's beginning to go into clinicians to try to understand how we can best use it. One way that we thought about it, and we talked with Dr. Bedlack, in this population of patients that have, they're carriers of the condition and they don't have anything, and they come to us and says, what should I do? We think that the key will be to check their neurofilament on a frequent basis. And if the filament goes up, even though they may not have weakness, maybe we do want to implement treatments sooner rather than later, because that might guide us with some validity.
Speaking of Dr. Bedlack, there's a question from Jose who on Dr. Bedlack's confirmed reversals. None of them attributed their healing to the R medications. Many used mental and oxidative therapy, ozone, CDS, yet allopathic medicine seems to overlook this data. What are your thoughts on those cases?
We do have one of the patients on that cohort came to our clinic. We sent all the information to Dr. Bedlack. I like Dr. Bedlack so much, like everybody else, and I have great conversations with him. We talk about this frequently, and he's a little frustrated, if I can say the way he feels, because he's done so much research trying to find the common ground and what it is, and it's not so clear about the treatments that were the reason that they caused. There were some common elements, and he did some of these trials and said, take some of this and see what happens, to see if you reverse, and he didn't find reversals. Lately, he's been checking some markers, some genetic markers, doing some muscle biopsies, and there seem to be some genes that they're beginning to have some commonalities in these patients. So there's some, I think he's opening the door, not on the treatments they have, but some of the genetic features that they may have in common, that they might find out, okay, this is why they reversed. So I think he's beginning to learn some of that, and I hope that there's more to come. There's a recent publication on this, and so I think they're going to be looking more and more into why they reversed, and they may find out why some of the treatments work, or maybe there were nothing in the treatment, but there's something else.
Thank you. Thanks for clarifying that. And thank you, Jose, for the question. Roberto asks, any study on nandrolone? Right.
nandrolone, like a steroid, I guess. So I'm guessing these steroids, most of what we have in terms of prednisone, and I'm not sure that I can quote anything on nandrolone or that. But usually steroids don't work. So I would say probably not, but I'm not so sure I understood exactly the compound, and I'm not aware of specific details. But definitely, if there's some specific question, there are resources, which is BEDLAC has the Untangle ALS, if that has been reviewed, it's going to be listed there, and they will give you a summary whether it is or not effective.
Great. Thank you for the great reference. Are you involved, or do you have any experience with the Healy trial regimen F?
Yes. So I'm proud to say that we are very involved with Healy. We enrolled one of the first few patients on F, and now we are just a few patients behind enrolling with Mass General. So we've been the top enrolling site in the country, and we have a number of patients with F. I have this question is, can I guess whether it's working or not? And it's very difficult. The first 6 months, there's 3 patients go on the regimen F and 1 goes on placebo. And it's very hard to tell who was in it and what it's not. Because the good thing about F is that I don't think it has significant side effects. It doesn't cause nausea. I don't think it's having anything else that I can say, okay, I'm still blinded. The medication is not causing side effects for me to say, okay, I know who's on medication, who's not. So I'm blinded to all of them. And to tell you that some patients do really well, really, really well. Others are progressing, but I don't know which one is in placebo and which is not. So the study has not been unblinded yet. I'm fully blinded. I cannot tell you who's in what. I can tell you, though, that the side effect profile in terms of adverse events is very clean right now. So we have several patients that already finished 6 months. Many of them have to be on medication. They've been doing well. The active arm also is doing very well. We don't have a lot of side effects. So I can't speak about no side effects or minimal side effects, if anything. But in terms of the efficacy, I don't know. I can't tell.
Thank you. Are there any markers, going back to markers, and thank you for, I know with trials, you always have to balance how much is shared when. So it's great to hear.
I'm not in the group that actually look at the data set on the back. I'm in the front with the patients receiving and looking for it. So I can tell you about the side effects, not the efficacy.
Yeah, great. Thank you. And are there any markers early in the disease that define who will be a slow progressor? Is that part of the research that's ongoing?
I think the best data right now comes out of Europe. They have models in Europe. They have large data sets. They follow them over time. And there are some factors that clearly show that they're going to be fast progression. One is very simple. And if we do an ALSFRS, let's say 1 year after somebody started, so the maximal score in ALSFRS is 48. So if you, in the first 12 months, you go from 48 to 28, it's 20 points. And it's more than a point per month. You're going fast. So even though you've been diagnosed a year later, if your ALSFRS is very low at the time of diagnosis and you extrapolate, okay, when I started this, my functional scale was 48, I'm going fast. So that's something that is kind of obvious. If you, after 1 year of diagnosis, you have a lot of weakness, you're a fast progressor. But why maybe? Well, other feature is that some genes, we know they go fast as compared to others. Sometimes it's tricky because even sometimes within one gene, the typical example is SOD1. Some patients go very fast with SOD1 and some patients go slow. But we know some of the variants. So if we know the specific genetic variant, we can potentially say, okay, your genetic is likely to go fast, or your variant may be going slow. So those are two things. The other is whether you have cognitive problems from the beginning. This is less frequent than having cognitive problems, but if you have cognitive problems from the beginning, there's an atypical ALS, and it's likely the progression to go faster than other things. There's another point is if you get diagnosed very quickly within 2 or 3 months, it's because your weakness shows very quickly, and it gets you to a clinic very quickly. And if it takes you 2 years, it's because your weakness has been so slow and so, not so severe, so it's coming like you don't notice it. It's because your progression has been slow. So if you go really fast, you say something is wrong here very quickly. If you progress very slowly, it might take you 2 years before you even go to a doctor. So those are some features, that we know that can be different. The other is when we do the examination, there's different ways of assessing, but those that have a lot of spasticity, they're very tight in their muscles, they're hard to move. Those patients tend to go slower as compared to those that are very flaccid, that they have a lot of atrophy from the beginning. We know the differences. But here is individual experiences and some of these clinical signs. But this is what I told you. If we can put all this information in an AI program, I think we're going to be able to tell progression with a lot of more accuracy. The European models can give us high, average, medium, and low, and very slow. So they can give you different tiers already. And I think those models are going to come to us very quickly, because the AI algorithms will help us with progression rates very quickly. And more to say is some are talking that if we have good algorithms to be very precise, that could be a way of doing clinical trials without requiring placebos. And so you're supposed to go this fast to here in 6 to 12 months. Okay, we're going to run the study against you on the model and no placebo. So we'll see if that comes, and I think probably will happen soon.
And an extra point on that too, it comes up a lot with the companies that we work with and the researchers we work with, that the more precise the measures, the more precise we're able to measure the ALS-FRS-R, for instance, and really stratify and identify the different types of progression, the better companies can define their trials for specific goals and target different subpopulations, right? So
yeah. There's some data, just give examples of what you said. If you come to a clinic every 3 months and we do a functional scale, what if we have somebody at home doing the functional scale every week at home in a fixed interval? So we will have, in 3 months, we have, several data points instead of just one that can be varied. So, and then also if we can measure more variables in a simple way at home, in the comfort of your home, without having to go to a clinic, the data will be more solid, more accurate, and more frequent. And then these models will predict in a more accurate way. And then I think that's the way we're going. If we do sensors and measurements at home on a more regular basis, then we know the progression rates a lot better than we've done so far.
Thank you. Linda, we've been talking a little bit about what does average progression mean. Especially, I think we've been covering that a little bit. So I'm gonna put a hold on your question, because we are also talking about precision here. And when talking about setting ourselves up for precision medicines, could you talk a little bit about stem cell treatment and its effectiveness?
So stem cell is the most sexy question. It seems that it's going to have the solution to things. The study that is being out there is Neuron study, and it's kind of an intensive study, because people need to have a big needle into the bone marrow to extract that stem cell. That stem cell is processed and cleaned and increased, and then produce the treatment. And the infusions are not easy infusions. They are doing by lumbar puncture, put in the fluid space or intrathecal space at a regular basis. So those are two invasive ways to extract the stem cell, and to give the stem cell is very involved. It can come with, the bone marrow with a lot of pains. The injections on the spine can come with, inflammation, can have meningitis, even though it might not be infective. It can give inflammation with headaches and nausea and vomiting. So I just want to point that out, that the stem cell as a treatment is not just taking an oral medication twice a day. It's a lot more aggressive treatment. So when you're talking about an aggressive treatment, and you're trying to look into cancer, for example, when you get chemotherapies, and that, you know, people will have hair loss and they vomit for several months, the expectation is you get cured, because you're going to go through a really tough time before you actually get to the better time. So that is my introduction to stem cell discussion. The other is there's many different kinds of stem cells. Some of them are extremely undifferentiated, very, very at the stem, at the very origin. Others are almost like motor neurons, you know, more differentiated, more specific, and everything in between. So researchers are looking at what is the right stem cell, what is the right amount of stem cell, how frequent we need to give. And if we have a reaction to it, do we have to have it our own? Can we get out of the shelf another cell line? Can we get it from a family member? There's a lot of questions that I don't think we have the specific answer yet. So I think stem cell is still a little bit earlier for it. I do hope that there's so much research on it, it will give us more information on it, because the researchers right now have changed the idea that the stem cells are going to go and seed and create new neurons, to saying, well, stem cells are very good healers of the neurons you have. So they change the environment, they can feed neurons, can protect them and get more injury. So not as much as replacing neurons, but actually protect the ones that we have. So I think there's more questions than answers yet in stem cell. But the science is really moving very, very fast. I just got an invitation from a company that is trying to run another one. So I'm looking to see what the details are, because we might have, towards the end of the year, open studies on stem cells. Right now, there's none that I'm aware they're enrolling in stem cells. So there's no opportunity. There's a lot of questions. But we might have studies coming towards the end of the year. And I don't know for sure that, but it might be.
Thank you. Really great, thorough explanation. So I lost one that I was just about to ask you. That's really more in the AI realm when it comes to repurposing. Are there any strong repurposing candidates that you're really excited about? In some senses, Prime C is a proprietary version of two cheap generic drugs. Is there any rationale for taking ciprofloxacin and celecoxib?
Celecoxib. Well, this gets a little tricky, particularly in a large group like this, because whatever we said, it can be taken a little bit off context. These are conversations that you really need to have one-to-one with your neurologist, and the philosophy that you may have, the risk that you want to take. I think antibiotics and anti-inflammatories can have side effects. I have to say, though, that the doses they're talking are really low doses rather than high doses. So the antibiotics, and so they're not the high doses that we give for infections. So come on the lower end, so expected probably less side effects. And it depends where you are. If you're somebody that you've been doing okay and your treatments and you're slow progressing, you might not want to take some risk. But if you're somebody that says, look, I want everything and I'm willing to take all the risk, maybe you are somebody to take it. And if you don't have time to wait for the final study, maybe you want to go for it. But again, you have to look. One of the things that we always talk with the patients is we have these 4 drugs, and there might be a clinical trial medication on top of that. So you're talking 4 and 5. And there's always supplements and vitamins. And you have to see, all of a sudden, I know people would say, look, I get up at 6 and I take this. I get up at 7 and I take this. I get up at 8, I take that. And then before I finish, I got to eat something and do something. Well, how many medications do you want to take? And then what is the impact of side effects, or do they interact, or they oppose each other? Do they help each other? Again, this is something that it has to be definitely individualized. The medications are there, probably going to be affordable, but you have to look at the bigger picture. Are you going to just have it super full time just taking all of this, and you don't have time to actually enjoy the rest? So I don't know. It's a tough question of how much is too much, and that, I think clearly that's individualized.
There's a general question about if are there any recommended repurposed medicines or any data specifically on mexiletine as a repurposed medicine for ALS? Is this a field that you're active in with repurposing studies as well?
Not yet. I'm coming. Mexiletine is mostly for cramps or things of that nature, but and there's cardiac medications that seems to increase muscle strength. So there's a number of things that are coming out there. The expert here is there are many people. Definitely, Dr. Bedlack is one that is really the champion of looking at else that is off treatment. He is kind of the person that will answer questions in a very appropriate way. I'm sort of more of a follower than a leader on this. I do take every time I have a question, I will go search it a little bit more, ask the people that I know, run it by the group. And like I mentioned before, the recommendation is going to be out of a group more than just me, because a lot of times these medication promise a lot. And then you call somebody says, yeah, I tried this 5 patients. Boy, they were vomiting, they were doing this. I stopped it because it has a lot of side effects. So one thing is somebody without ALS taking some of these medications or for another condition. Another thing is taking this medication in a person that has ALS and many other medications. So I go with caution, trying to be proactive, depends on what the patients want to do with themselves, and then what the information that I have, particularly in terms of side effect and also in cost. Sometimes cost is critical here.
Thank you. Yeah, and by the way, you mentioned Dr. Bedlack. He's come up a couple of times. He's actually our next speaker in 2 weeks. So we'll, for those in the audience, these are exactly the kind of questions that we'll be able to say for him as well. So please join us then.
Yeah, write him down and hit him.
I'm going to skip ahead a little bit. There's been some really good conversations and questions in the chat. One thing that comes up, and it triggered my thoughts on this too, was there's another EAP out there that's coming from on T cells and Tregs. So could you discuss Tregs at all and your thoughts on that as an option?
Again, so this is a whole new line of treatments, which are called cell treatments. So there's a number of cells that we have. They're nucleated cells in the bloodstream, and they have different functions. So T cells have a lot of immune-related aspects of it. So they not only it's not like giving one drug. When you give a cell, the cell can produce different chemicals and produce different signals and have different factors that will help the immune system to modulate. So here, these cells seem to have a benefit on the progression. So they are beginning to be used as a cell line. There's B cells, there's T cells, there's combination of cells, and people are looking to cells as a modality of treatment. T regulatory cells is kind of the one that is coming to be tried. I don't think we know, is it in early stages to actually say whether they work or not, but there's a lot of excitement about, because it's a whole new treatment as a line of treatment. It's just not a drug or a surgery or different thing, but it's a cell treatment. Like it can be stem cell. Well, this is a much more differentiated. It's a T cell that is going to be infused.
Thank you so much. McFinn, how are we doing on time? You've been so generous with us to keep answering questions. So I just want to make sure we have a time check.
We are fine because these questions are so important. Thank you.
All right. So Dr. Locatelli, there's another comment similar to the prior discussion about Dr. Bedlack, but abnormal proteins have been found in cerebral spinal fluid of persons diagnosed with ALS in several recent studies. What are your thoughts of cerebral spinal fluid paresis?
Wow. I don't, first of all, the experience of doing that is very limited out there. So paresis means just, if I understood the question, is how about removing spinal fluid and inject maybe normal saline or filter in spinal fluid, put it back. So like we do plasmapheresis for people with, inflammatory neuropathies, like CIDP is one of them, or GBS, which is Guillain-Barré, in which we remove the plasma because it has antibodies that are attacking nerves, and then we put clean ones, so we diminish what is attacking the nerves. So if these are normal proteins are toxic to the brain, the idea of removing the toxic protein out of the spinal fluid and replace it with fluid that doesn't have those proteins, it might diminish the amount of toxicity given to the brain. It's a good hypothesis. However, I had to say, like I was saying, from stem cells, these are more aggressive treatments. Removing the spinal fluid when the pressure gets lower, it will give, just because it's low pressure, it will give you headaches. And when you put something in, you got to be very careful that it will not produce also a inflammatory response by itself. So I'm not aware of any trial, maybe something coming out there, but so I know that if you're trying to clean the spinal fluid, it's a good idea. The question is how easy or complicated, what are the side effects?
It's currently still in animal studies in mice, so we'll see how it comes out. There was a question reposted that I missed earlier, but so thank you, Robin, for that. Pridopine and Nuedexta improve speech, but not arm or leg function. Should either be added to all speech onset patients? What are your thoughts on its applicability?
Yeah, Nuedexta, dextromethorphan, and quinidine. Actually, it's a medication that it has an indication for affect or pseudobulbar affect, and something that could be a symptom in ALS. In our center, Dr. Lauren Tabor, our speech therapist, and actually the co-director of our program, a PhD with tremendous skill, received a grant from the ALS Association. So we studied Nuedexta, in which we did swallowing study and a speech analysis, a baseline. We give Nuedexta for 30 days, and we repeat the evaluation. And we show a significant impact and benefit in speech and swallowing. So Nuedexta does have a significant clinical benefit. So it improves symptoms, and it does it quickly within 30 days. So in our practice, and particularly with Herbie in our program, and we specifically look at these parameters and as a baseline, and if there are deficits, we will come out with the Nuedexta and trying to see if we can improve the speech and swallowing. And we have seen the improvement quickly, so we use it frequently. So if somebody doesn't have deficit, we don't have to give it. But if we notice things, we will treat it. It's a sigma-1 receptor drug, pidopidine, which is this expanded access program. We were expecting, because of the mechanism was similar to Nuedexta, we said, well, that will be interesting to see what happened with this compound. We were anticipating that compound was going to help speech and swallow, and it did. So I think that has a symptomatic impact at least. So there's some now really good evidence that this activity will, has an impact on that. So this Nuedexta and this compound, this company Prelenia will probably have a significant impact or symptomatic, at least symptomatic improvement on the speech and swallow with medication. So we have a very low threshold to use it early on.
Thank you so much.
Thank you so much. We have approximately 5 minutes left. I've left this go on for question and answers because I think that it was the most important value that we could have today. So I want to just say, Christian, do you have any questions in there that you want to grab?
There were probably two left that I just wanted to quickly. One was more general about off-label treatments or other supplements. If there are any other supplements, especially along with B12, that you thought you should be called out for people that might be really useful.
I would say my approach to that is, tell me what's on your mind, what you read, who recommended what, and I tell you no to that. You may want that one. But again, I like to also bring the issue how many things you're taking. Again, I don't believe that this should be given to everybody across the board. And so I don't have a recommendation for a specific supplement.
And are NAD infusions beneficial?
Now that I know, so I know a lot of people go to different centers. They pay good money for the infusions. There's some data that you might say that it is effective. So the infusions seems to, have the idea they could be more powerful. I'm not aware of any study, double-blind, randomized showing, ALS disease progression changes. But there's some studies that say probably it is. There's an oral compound that it has a combination of two things that there was a little study on it. So there's data to say maybe, so and probably safe. But again, not yet to the level of knowledge to other things.
Thank you so much. There was one question: if there's a way for people to be able to get in contact with you, is there an email that for the center or for the program or for you directly that they can send to if they have additional questions or would like to be seen at your clinic?
Yeah, so it's my name, Eduardo.Locatelli @nova.edu. That's the email. You can probably post it on the chat, and I'll hopefully survive that.
You might get a few.
Yeah, no, it's so one of the things that I think we pride on this center that we continue to build day to day is to trying to have access and trying to be proactive on reaching out patients and trying to see them quickly if we have to, and be very proactive in communicating. So we give our emails and even phone numbers and everything to all of the patients that we have. They reach us at any time. So happy to answer the emails and on call, make phone calls if that's necessary.
Thank you so much. And I am going to drop the email in the chat. Just I'm making sure that I copy it correctly. So, but it is a pretty straightforward one. So thank you for that. You can thank your IT team for that. We've covered about a lot of ground. We have covered so many different questions. Thank you so much for the time. And we're going to hand it back to McFinn, but Dr. Locatelli, I met him personally in Switzerland. He's the real deal. He is every bit the generous patient man with every question you have in person as much as he is here tonight. Despite my little rivalry with him because my family's from Chile and he's from Argentina, so we've got a little soccer rivalry that we can rely on. But thank you so much for your time tonight. We are incredibly grateful for the care you provide and for all the advice you offer.
Well, I definitely would like to thank you and Indu and the whole team about it. I can tell you, I'm totally impressed of the number of patients in this venue. I think it's the most important thing is to actually do this together. It really, I'm really. I don't know what the really word is. I'm excited about seeing everybody participating, trying to learn, making questions, putting pressure on us. So that is something that gives me energy. So if I have some questions that I didn't know for sure, I'm going to go search them. So pushing us is part of the deal. And I think you guys have made a big change on ALS. The PALS, not only going to Washington, but talking to us, coming to our conferences, asking the question, putting pressure on us, putting pressure on everybody, has changed the dialogue here. I'm so happy to know that it's just not the doctors on one end and the patients on the other end, and that we're actually together on this, and everybody's pushing for better and helping research and science. And I think together we'll figure it out. I think the hope now is greater than ever it has been. And so I thank for everybody being here and ask me all these questions. And I thank the team, Everything ALS, for the opportunity, for sure.
Thank you, Doctor. Back to you, McFinn.
Want to add to that folks, look who came tonight to your living room. This is not a job for the doctor. This is his passion, is what I feel. And so absolutely. So each of you who came tonight, you just showed the doc how important he is, how important his message is, and how important you are, because this program is about you and whatever we can bring to make your day a little more practical. So for all of you who came, I can't say more than We're in this together, and we are here to support each other. So in 2 weeks, let's do this again. And just one more reminder, next Wednesday is Valentine's Day, and we will have our fireside chat with big hearts on. So if you have time next Wednesday, come and join us and bring your love and share it. Now, everybody tonight who you saw 176 folks were here tonight. So I want you all to feel like you should say good night with a big smile to all of the people here. So on 3, let's all say good night together. 1, 2, 3.
Yes.
Good night.
Good night. Again.
Thank you, doctor. Thank you.
Good night.
Thank you, doctor.
Night. Thank you.
Michelle, Sherry, Michael, John Michael, Elizabeth,
Thank you
your
very
smile goes
much.
forever. Thank you, and Joe.
Bye-bye.
Yeah,
Thank
Jose,
you.
see you in a week. Sean,
Good night,
it's so a
everybody.
pleasure to meet your angel. Sherry, you keep that smile going. And Dee Dee, you are an ALS warrior, dear. Thank you so much. And Tony, keep that smile going. And give that lady next to you a hug, because I know that she gives you hugs constantly. There you got it. That's why we're in this together. All right, everyone. Thank you.
Thank you.
Thank you.
Thank you.
Thank you, Deb.